Recording in progress.
I guess we're just doing questions like this. My question is for West Virginia. So I really liked your model. I'm an epidemiologist myself. I have a question about your linkage to non-fatal overdoses. I thought your poster was really interesting about how you did see a decrease in prescribers' opioid prescribing. Did you receive any feedback from prescribers about the reports that they received, about like if they would like to continue seeing those, if there was any additional metrics, maybe any linkages to the prescriber report cards that they received as well?
I believe my EPIs, they're in the process of accumulating some of those, because they reached out to some of these folks that they, especially the ones that they sent multiple letters to, but we've been working with the medical boards and getting easier ways to contact them than through our system. We're going to do a presentation like at like a medical conference and kind of give a better explanation, because the email we send is clearly limited on how much we can provide, but we're looking to interact with them more at one of their own conferences, more of a where they can actually, situation like this, they can ask questions, but we don't have any analytics of what these responses look like, but we are collecting them, but I'm not sure what they are yet, but they have those available and they'll be producing something on that here in the near future.
Thank you. If you don't mind me asking one follow-up question, for your non-fatal overdose data, is that based off emergency room data? I saw it, the number 2 comes from vital statistics, but I'm assuming that's from emergency room data.
Right. In our state, all of the EMS reports, all the run data that's all across our counties reported centrally to a state entity. So whether it's a county in the other end of the state or whether it's an ER, all of that data is collected centrally in our state. And they have direct access that they work with all these folks to, because their data was kind of bad for a while. We actually worked with them to clean up their data. And a lot of it was literally a word search. Like they'd look at like a summary of a EM, because we had some incidents that were reported as or as overdose incidents because it had the word fentanyl in it. What turns out, they administer fentanyl in some ambulances somewhere. So in the summary of the run, it says we administered fentanyl for a car wreck. Had nothing to do with an overdose. So we had to,
all right, I'm unmuted. Can you hear me?
The data collection folks to get that cleaned up. So now we've got a pretty good handle on it. Every once in a while we'll have a weird report that looks like an overdose, but turns out not to be. And we have a mechanism to back those out. And we get contacted all the time, whether it's by patients or physicians saying, hey, that's not an overdose. So we do have some little issues we work with once in a while, but the process right now has been fairly smooth.
Thank you.
All right, are we up and running with the presentation? Can you guys see me? All right, good morning. My name is Kara Slusser. I'm the director of Inspect here in Indiana. That's our state's prescription drug monitoring program. I'm going to go ahead and share my screen with you so we can get started on the presentation.
And at the conclusion of her presentation, if people have questions, definitely come up to the mic because she won't be able to hear you otherwise.
Well, Kathy, thank you for accommodating me today. Appreciate that very much. So first, I want to talk a little bit about where we started with our data collection back in 2018, and I'm going to show you how we have progressed into collecting more accurate data. So in the state of Indiana, we team up with an organization called the Management Performance Hub. We refer to it as MPH. And this is essentially a centralized data hub that collects data from various state agencies, and they can help us combine various data sets to identify various drug trends. And back in 2018, obviously, this is a dashboard from 2014 to 18, we were able to use some of that data from EMS and from our arrest records and combine that with our PDMP data to identify individuals who had EMS runs in addition to an opioid prescription. We also looked at our ER data. So we identified individuals who had an EMS run, an ED visit, uh, individuals who died from an opioid related death or had an arrest for a drug related crime. Now, the problem with this, though, while this was, at that time, I think it was great data, at that time, we were still unable to identify what type of opioid prescription was, or I'm sorry, what type of opioid was actually administered to an individual at the time of death. So we could identify if they had a drug in their system. We could identify if they had a prescription from the PMP, but that was about the extent of it. So we were unable at that point in time to identify just what type of drug was in their system at the time of death. And when we were using the opioid pathways dashboard, we identified that 99% of individuals with an opioid prescription hadn't had an opioid related event. However, of all the individuals prescribed a controlled substance, the relative risk of an opioid related event was 3.6 times greater for those who had an opioid prescription than those who didn't. And 54% of those individuals reported receiving naloxone during an EMS run and had an opioid dispensed to them at some point. The 74% of the individuals with a reported ED visit for an opioid overdose have an opioid dispensed to them at some point in time. And I'm sure if you can see the bottom here, but 72% of individuals with an opioid related or a reported opioid related drug poisoning death have had an opioid.
Kara, I'm sorry to
Yes.
interrupt you. It's Melissa.
Mhm.
Say, your slides aren't advancing for us, and I just hate that we can't see them because I know you spent time
Oh, okay.
preparing them. So,
There. Okay. Can
okay.
you see this that says opioid pathway summary at the top?
No, we really are just seeing the view. It looks like, before you would like click on slideshow, it's just the kind of listing of slides on your left, and then just it's still your introduction slide.
Oh, okay. Well, this is odd.
Can you click on slideshow at the top there, and so it shows full screen?
That's actually what I did. I did
What you
click on
did?
slideshow.
Okay.
Yeah.
Maybe then
So
we're seeing.
I'm seeing it as in the presentation version or in the presentation version. So,
Hey, Cara, this is the tech engineer there, Nate.
yes.
In the window that you opened up, the black one where it has all your controls where you advance the slides, there should be a button there that says switch presenter and display view. Hit that button.
Where am I looking at that? Sorry, is that in my?
After you hit start slideshow.
Okay, let me go back here. Yeah, I'm not seeing that. I'm seeing display settings. Where can I see this? Oh goodness. All right. I've never had that happen before. I've always been able to present that in or show this in presentation view. So are you still not seeing the dashboard?
No, we're not.
Gosh, okay. Let me see if I can try something here. going to try sharing one more time.
If you start the slideshow and then go to share screen, you should be able to select which screen to share in.
Yeah, that's what I was thinking. All right, are you now seeing it in presentation mode?
Yeah, that's it. Thank you.
Okay, great. Okay, can you see our opioid pathways user story? All right, let me know if this is not let me know if you are not seeing the dashboard being displayed here for opioid pathways.
Yes, we see 3 circles at the top.
Perfect. All right, great. Thanks, John. Okay, sorry. So this is what I was trying to display earlier. So this is the data. This is the opioid pathways data that identifies individuals who have either died of an opioid-related event. It looks at EMS naloxone runs, ER visits, and individuals who have had an opioid prescription uh, between 2014 and 2018. So as you can see there, we're seeing individuals who died from a non-opioid poisoning, individuals who died from an opioid drug poisoning, and then you can see the relative risks here. And like I said, we also incorporated some arrest data. So this would account for arrests or drug-related incidents. So again, this is the opioids pathway summary. So this dashboard examines the opioid issue from 4 perspectives. So we started with all individuals who have either filled a prescription, received emergency medical services, visited an emergency department, or died beginning in 2014. We then compare how many of those individuals have had one of the other 3 types of incidents. So we're looking at overdose deaths here. 72% of those individuals with an opioid-related drug poisoning death have had an opioid dispensed to them at some point in time. And as you can see there, the 54% of individuals who reported receiving naloxone during an EMS run have an opioid dispensed to them at some point in time. Now, I want to point out 2 pieces of legislation here because this has dramatically changed the way that we collect and report drug overdose related incidents. The first one is IC 1631-323.7. So this ensures that emergency medical technicians, community corrections officers, and emergency medical first responders, firefighters, volunteers, basically any first responder who administers an overdose intervention drug or is summoned immediately after an overdose intervention drug is administered. They do have to report those incidents to the state, and that is reported through our EMS reporting system owned and operated by Homeland Security in Indiana. The second piece of legislation has to do with coroners. Now, anytime a coroner believes there is an individual who has died from an accidental or intentional overdose of a controlled substance, they have to do the following in Indiana. Number 1, they have to query inspect for the patient's PMP records and review the prescriptions that were issued to them. They have to extract 1 or more bodily fluids from the decedent. They have to test all of those bodily fluids extracted to determine if there are any amounts, including trace amounts, of a controlled substance at the time of the individual's death. They test bodily fluids extracted for any amount of xylazine. Now, I know that a lot of you know that we've had a tremendous issue with xylazine over the past few years, especially incidents where people are combining xylazine with opioids. And that has caused tremendous issues, not only increased the rate of overdose, but has also caused some additional opioid-related incidents. So they are now testing for both opioid controlled substances and xylazine. Now, all of those results have to be reported to the Indiana Department of Health within 72 hours of completing the death investigation. Now, both of these two pieces of legislation were passed in 2018. And as a result, not only of the legislation, but also the training and education that we're doing with coroners and first responders to make sure that they understand their obligations under the law, how to report fatal and non-fatal overdose incidents, how to report naloxone administrations, and all of these things that we're doing with our coroners. Sorry, there's a little bit of background noise here. Sorry about that if you can hear that. So anyway, because of all the training and education that we're doing, we have been able to collect data in a much more much more consistently. And so the data that we're collecting is much more accurate, and we're getting it in a timely manner. So using the information that's now being collected as a result of that legislation, first of all, we're able to provide more accurate data. This is our dashboard that goes up to that collects data up to 2023. Obviously 2024 data is being collected, but we are not able to display that just yet because we're not all the way through the year. But we're able to look at individuals with substance use related events by opioid script history. And you can see individuals with events with no opioid script history, events with opioid script history, and total individuals here. Also, as a result of our legislation concerning coroners and the data collection that they're doing for individuals who died of a suspected drug-related overdose, this is the percent of substance use related events by drug category. So you can see individuals that had some form of alcohol or illicit drug in their system at the time of death versus individuals who had polysubstances. So individuals who had overlapping opioid and benzo, for example, individuals who had overlapping opioid and xylazine in their system at the time of death. It gives us a much greater perspective on what we're dealing with when we look at individuals who have died from a drug overdose with it, and what type of substances are in their system at that time. So the methodology for this, I'm going to print out the data for this dashboard comes from the Indiana Prescription Drug Monitoring Program, INSPECT, the Indiana Department of Homeland Security, which runs our EMS reporting system, the Indiana Department of Health Emergency Department data. They do collect data from emergency departments, including ICD codes, and the Indiana Department of Health's vital records data. So an individual is classified as having experienced a fatal substance overdose if at least one of the following conditions is true. So first, they're identified by the Indiana Department of Health vital records data as having experienced an overdose. And second, as assumptions being made. I'm sorry, my my home alarm system just went off and I have to disarm that. I'm sorry. I have guests in my home and I apologize for that. All right, fix it. Okay, second, an assumption is made when the date of death for an individual was within 48 hours of an EMS event or ED that is classified as a drug-related event. Now, like I said, we do collect ICD codes. So all of that information that's being collected in emergency departments, in hospitals throughout the state of Indiana, as soon as those ICD codes are released, they are submitted to both the Hospital Association and they are submitted to the State Department of Health. They are also looking at data published by the National Institute of Health, which indicates likely drug-related events. Also, as an individual classified as having experienced a non-fatal substance overdose, including this includes individuals identified in emergency medical systems (EMS) data as experiencing a non-fatal overdose event. I do want to point out something important here. Now, every time naloxone is administered to an individual, yes, the first responder does have to report that to the EMS system. But one of the issues that we have discovered in that data is that it doesn't necessarily identify that as a non-fatal overdose event. Now, all we know at that time, looking at that data, is that naloxone was administered. That could mean that the individual was non-responsive and therefore naloxone was administered. It does not necessarily mean that it was a non-fatal overdose event. So there is a little bit of a gap in that data, and that's something that we're working through, trying to collect additional data on each individual who was administered naloxone to identify which ones were actually non-fatal overdose events and confirm those. So that is something that we're looking forward to identifying better in the future and trying to improve the way that we collect data on non-fatal overdose events reported by first responders. And lastly, these individuals are identified by emergency department data for symptoms and drug-related events indicating a non-fatal overdose. All right, please let me know if anyone has questions about this. All right.
Hi, Kara. This is Kathy from North Dakota. I was wondering what seems to be the most popular data point, and this goes out to everybody that just presented. I know that MME was very popular with our state, but can you pinpoint a couple of key analytics that you would say are very important to your stakeholders right now?
We're getting a couple of different things. Number one, we're being asked for information about overdose events. And I always, unfortunately, I have to direct them to a public dashboard. I mean, we do have public facing dashboards now that start combining some of these data sets because we're consistently asked about this. So we have a portal now for any individuals who want to check this data. So it's all public facing, and we're able to kind of point them to, our fatal and non-fatal overdose dashboards, and then things like this that combine various data sets. But I will say the other thing that I'm consistently asked about is OTP data. I don't believe, maybe feel free to correct me if I'm wrong, but I don't believe that any state PMP is currently collecting and displaying OTP data. That's something that practitioners are consistently asking for, and it seems to be a really important part of identifying individuals who are suffering from substance use disorder. And of course, there's such a gap there between them, these individuals seeking treatment at an OTP and then going to another doctor who has no idea that they are even seeking help for substance use disorder.
Thank you.
In our state, we get our most feedback, positive feedback, from our doctor report cards, just because they can look and see. We get a lot of calls where they don't realize that pharmacies make mistakes, and they're seeing information on dispensing types of drugs that they don't dispense at all. And we have some areas where there's a lot of, there's some Smiths, Dr. Smiths, one of those, literally Dr. Smith, not just the making up Smith, but where the similar doctors' names are getting reported, they just, from the drop-down box, they're just picking the first one, and that report card's one way they can see these prescriptions that aren't theirs. They have the functionality to go in and do a self-report, go back so many months, and that triggers that. Once they see some drugs in this report card that they don't recognize, then they go in and do more research on that sort of thing. And we work with them to get those cleaned up with the pharmacies.
Thank you, Mike.
With us, Kathy, it's going to depend on who's making the request for it. You know, from our regulatory boards and from that aspect, quantity and day supply has creeped up this year where they're asking, we want those numbers and want to see where they're kind of trending. But in state of Florida, it's been the quantities of certain drugs and the day supply. And the only thing I can think of they're trying to figure out is, are the prescribers, healthcare practitioners, changing their prescribing history or habits over time? From the practitioner side of things, it's just more inclusive. If I'm going to eForce, the web portal in general, I want to see more. What else can we put in here? Naloxone administration, like South Carolina has, and non-fatal overdose, Ohio, those type of things. The practitioners are wanting to see more of that from the web portal aspect. And if you're looking at the PMP team, we're looking at more of the integration solution, the gateway results.
Yeah.
How can we put more functionality on that side of the spectrum?
Gotcha. Thank you, guys.
Question for the panel as a whole. The dashboards and report cards, provider outreach, all looks incredibly valuable. Has there been any contemplation of doing that at the pharmacy level? Because I could see a lot of this would be just as useful to pharmacies as well to be able to see that kind of data.
No, not from Florida. Jamie, if I'm mistaken, wasn't you seeking that at one point in time, a pharmacy report card or a dispenser report card? Yeah, so I was actually waiting on Arkansas to see how that kind of went. But that was brought up. Jamie had a great idea as far as a dispenser report card to kind of let them know where they fall among the metrics, but I don't know what happened with that. Oh, okay, yeah, still in the planning stage.
Okay.
But I agree with you. I think it would be helpful to show, even from a dashboard perspective as well.
Yeah, very good.
We have our EPIs working on, and one of the things they're looking at, it's the dispensing data. We're using it to identify some buprenorphine, Suboxone deserts in our area, and we've been contacted by our prison system because they have a lot of folks in West Virginia in recovery in prison. And when they get out, they want to make sure they continue their care, and they're asking us for dispensing data. Not necessarily a dashboard, but something that they can look at to, when these patients get out or these prisoners get out of it, they're no longer incarcerated, where can they direct them to get their prescriptions filled? And it's almost a dashboard functionality we're trying to come up with on ways to kind of help them, continue the care of their prisoners once they leave their custody. But we haven't got there yet because it's one of those things we're not using the data. We're being too specific with the data and could run into problems. We'd have to get some releases maybe with the pharmacies to be able to produce this data or to share this data with them. But we're working on that right now, also in a planning stage.
Mhm. Yeah, Mike, I think that's a really solid point because that's, I know Indiana is dealing with that quite a bit as well, and I'm sure every other state is. Obviously, people who are coming out of prison, I think there's a tremendous gap there where we can't really direct them to specific places, and I know they're trying to figure out where to go to get that continuation of care, and I think they're at a significant risk within the first 30 days of being released. So I think that's a really solid point.
My question was for West Virginia and the other two if you do this, but it was about, you showed one slide which looked like what we call outlying providers or higher risk prescribers and the data points that you're doing to put that together. And so you're looking at the top 5%. Do you worry at some point that someone's always going to be in the top 5%? Or I know we started that way. We're looking at 2 standard deviations above the mean for certain metrics, but eventually everyone's going to start to regress toward the mean. So that was one question. And the second question is, did you say that you generate those people who are identified agnostic of specialty and then send them onto the boards and then the boards look at them?
Right, and you're right, the same folks are in this top 5% every time. They're always on the list. And when the medical boards receive those lists, they automatically, once they've already investigated, they've been on the list so many times, they open a case, they determine that those people should be on the list because of their practice types. That's on them. We just provide the data. We're working on changing the algorithm a little bit to adapt to some of these things. Like I say, we're looking into also, like this has historically been geared for Schedule II opioids for the most part, but we're looking to expand this more into the APRNs and the mid-levels and gear it toward other things, include other drugs besides the big opioids. But we're not looking to change, like I say, we're just giving it to the medical board and letting them determine if they're truly abnormal or not for their practice. But we don't distinguish on what the practice type's on the front end.
Hello, I have a question on the prescriber dashboard component that you talk about. I understand that they would be able to see kind of their own data, but do you provide them some sort of a comparison with other specialties or their peers? So if I'm an internal medicine doctor, I can see what my percentage of C2s are versus, C3 through 5s versus opioids versus all those different drug classes. Can they see where they compare to their peers? Or is it just exclusively their own data?
I'm thinking you're looking at me, right?
Kind of, because you mentioned the prescriber dashboard multiple times, so.
Right, well, I'm trying to think back, like I say, that's, my EPIs do a lot of that, and my vendor works with them. The issues we have is the specialty that the practitioner, when they set up our account with me, they select their specialty. And what happens, a lot of doctors don't do 100% of the same specialty every day. So we just have them do their best guess on what the majority of their practice is. We don't have the functionality yet where they can select a different specialty and see where they compare then. But we've discussed that where they can, because we're having them now select a second specialty in our system during you go back and change their account with me to add other specialties. So we're looking at how to break this down, how to separate it by, because we get these guys that are looking, their main practice is, I'm an obstetrician, but it looks bad among obstetricians if I'm doing a bunch of MAT or a bunch of Schedule II opioids. But getting the message out that they're the only one that sees those. The other obstetricians don't see that. So that's the first thing that we're going to tell their medical board. But just getting them to understand that this is just based on how you report yourself, what your specialty is, and you're the only one that sees it, and you're comparing yourself to whatever specialty you select. But we're looking at kind of doing a secondary list of other practices, because clearly everyone doesn't do the same thing most of the time. We're looking at making those kind of modifications.
Yeah. I think the specialty, well, especially with the, PAs and nurse practitioners, that's a big challenge because it's such a broad general group. And so you might have somebody, I'm from the retail pharmacy side, and when we're looking at analytics, we want to find those doctors that are above, their peers for that specialty. But when you've got such a broad category, it makes it very difficult.
And in our state, I'm sure every other state, the APRN's practices continues to expand. And right now, I think the APRNs, the only difference between them and an MD is that their limitation on Schedule II stimulants. Everything else, all other Schedule IIs and any other schedules, they can write the same kind of prescriptions that a DO or MD can write currently.
I'm just curious if a prescriber were to see, where they fall amongst their peers, if that would change their prescribing patterns in any way. Can I have that insight?
I was going to add, I currently don't have the prescriber report card feature with my vendor. I turned it off because I think it needs to be beefed up a little bit. But typically with the prescriber report modules, wherever you're getting it at, it is doing a role type specialty comparison among that group. So when you're getting that report as a practitioner, you're being compared to your counterparts within your specialty. That's the default kind of normal function of that.
Great.
So,
Yeah, thank you. I think the challenge is them updating their specialty when they start branching out, so.
And I want to also add to that, another thing that I really think is important there is the fact that those quarterly reports identify each of the patients that have exceeded various thresholds, right? I mean, it automatically identifies any patient that maybe has some concerning patterns in their PMP history, so that the individual practitioner reviewing that can very easily click on that and review that list of patients to see if there's anything that warrants further investigation.
Yeah, that's a great point. Great, thank you.
all right, Haley, I think this is where you're supposed to say, if there's no other questions, we'll wrap this session up. She's gone? Oh, thank you. We want to thank John, Mike, and Carrie for that session.